This is episode 131 of the Swallow Your Pride podcast, and today's guest is Jackie Connell. She's an SLP with over 10 years of experience, primarily with the adult population in the acute care, acute rehab, outpatient, and home care settings. She received her master's degree from Loyola University, Maryland, and is currently the lead SLP at NYU Winthrop Hospital, a level 1 trauma and primary stroke center located on Long Island in New York. Jackie has a strong interest in neurogenic disorders relating to swallowing and communication, and is taught as an adjunct professor at the graduate level.
Welcome to the Swallow Your Pride podcast. I'm your host, Theresa Richard. I'm a board-certified specialist in swallowing and swallowing disorders, and I know firsthand how much confusing and conflicting information there is out there about how we assess and treat swallowing disorders. This podcast is all about bringing everyone together, getting on the same page, being open to new ideas, and using evidence-based treatment strategies for our patients with dysphagia. So let's get into it. Just a quick disclaimer that all statements and opinions expressed in this episode do not reflect on the organizations associated with the speakers and are their own opinions solely.
Hello, everybody. Welcome back. I'm really excited for this episode today, and I say that only because I think it's going to help clarify a lot of things that I know a lot of people are struggling with across the country right now about what do we do with scheduling and how are we supposed to triage these patients in the midst of COVID-19. So I was really happy that Jackie agreed to come on and talk about this. And she, the reason I had asked her to come was in the MedSLP Collective, we're having a weekly support call for our frontlines SLPs in COVID-19. And she had some really good suggestions to help support her colleagues last week, which is why I asked her to come on and share those with all of you guys. And I do want to say that the MedSLP Collective is open for enrollment now. If anybody's looking for some extra support, you can go to medslpcollective.com to sign up. Also, if you are a graduate student or an undergrad student, well, we do have a student rate available at medslpcollective.com/student. So I hope you all enjoy this episode with Jackie and hope she helps to clarify some things. And I hope everybody's staying so healthy and safe out there and protecting themselves. Good morning, Jackie.
Good morning, Theresa.
Thank you so much for joining me.
Thanks for having me on.
Yeah. So tell the people who you are.
So I am Jackie Connell. I am a speech pathologist at NYU Winthrop Hospital on Long Island, which is located in New York. I've been practicing for a little over 10 years and primarily in the acute care setting, but I've done outpatient, home care, acute rehab. I'm currently the lead therapist, so I have a team of 6 that I oversee and mentor. And that includes pediatrics and adults. So I'm also learning new things every day. Yeah, that's kind of who I am.
Awesome. Well, thank you. So I asked Jackie to come on today. So we, in the MedSLP Collective, we started doing a weekly support call for basically everybody that's dealing with patients with COVID-19. And Jackie just had some really good insight on our last support call that, especially as leading a team that's in New York, that's leading the charge basically in this. I just asked her if she'd come on and kind of share some things because I think everybody has some questions on how to deal with this and what's the right thing. And I think I just want to stress more than anything that there is no right way, I think, to do any of this, and it really has to go based on your own hospital policies and your own infection control policies. But hopefully you can just get some good ideas on how to even tackle the problem solving here with Jackie. So,
yeah. So I would say one of the things that we started with, and this was a suggestion actually from one of my staff members that I was able to not necessarily escalate, but kind of go with a plan and get it approved. And one of the thoughts was initially limiting our exposure to each other because we're a small department. And if one of us gets sick, then there's no speech pathologist in the entire hospital. And also limiting our exposure to our patients day in and day out. And so initially, and I think because we're in New York, we're ahead of some of the other states in regards to how we're managing some of our caseload and some of our staffing. And so we made that change early on. So what we did was we shifted everyone from 5 8s to 4 10s. So we had one less day for each therapist in the office, in the hospital. And we also had an extra day at home, which I think right now the mental component of that is huge. Yeah. And my staff has all given me positive feedback on that. And I've made it very clear because my director wanted me to make it very clear that this is a temporary situation. But it's one that's working both for our patient care and our self-care, as a department as well. And so by limiting the amount of staff in the office it's great because you're exposing, one another to each other less. I think most speech pathology offices are like broom closets. They're really small.
Yep.
So it's impossible to social distance in those. And so that was really successful. That was something that we did. We initiated that. It's been a positive thing. And when I took it to leadership, I have autonomy over the schedule to some degree, but I still need to get certain things like that approved, because one of our initial thoughts was actually 312s, and that ended up being much more complicated because in our job code in the time card system, it doesn't allow us to put in for 312 because the extra shift and whatnot. So then we went back to this 410. So even just learning things like that as you're going through this crisis, for lack of a better term.
Yeah.
So that was one of the things we did in regards to staffing. And actually this past weekend, I was able to get everyone on my staff remote access to their desktops at work. So we've gone even further with this in regards to managing our caseload. So obviously our caseload has taken a hit. We are a fraction of, we're seeing a fraction of the patients we normally do for two reasons. One, I think a lot of them are very sick and they aren't in our facility. They aren't being extubated yet. We're still at the point where they're still intubated. So we haven't seen that influx of extubated patients and needing the swallow consult at this point in time. I think that's going to hit us about this weekend. And so with the caseload being lower, we are having opportunity to do a lot of in-house, in-services, CEUs, just, team building. I actually had the ATOS reps. We had a CEU conference set up to be in person with us, and we were able to make that a WebEx, for 2 hours, and just kind of really focusing on the learning environment that we don't often get time to do. And so with having IT get everyone remotely set up, I'm now able to have one therapist at least start their day at home. And so they can log in, they will check the caseload, they will check the census, and we have what we call a COVID list. So we have a running list on Epic that is all of our COVID PUIs and all of our COVID positives. And the therapist at home is responsible for triaging that list, so that the therapist at work can go see the neuro, the strokes, the, emergency surgeries that are still happening because people still have heart attacks. That is going well. The two therapists or the three therapists, because either three of us, in yesterday, are all communicating throughout the day, whether it's through our Epic chat or whether it's through our cell phones. And I think that that's a big key, is that you have to have a supportive team to pull any of this off right now.
Yeah.
So everyone has to kind of put aside whatever differences they may have had, which in my department, thankfully, we didn't have a lot. But I think that we've done a really good job of having each other's backs and coming together. And I'm seeing patients, which sometimes I don't because I have a lot of administrative responsibilities. But the first COVID patient, I felt like it was very important for me to see so that I could speak to, how do you put your PPE on? How do you do your check? How do you take it off? Just working through all of that, because we get trained for it, but we often don't really think about the severity, and you don't think about doing it day in and day out. Yeah. It's different now.
Yeah.
And it's important that we protect ourselves just as much as we protect our patients. And I think that's a big piece of this, is if you're not sure about whether your mask is fitting correctly or whatever it is, check with a nurse, check with someone who's putting it on more often than you are, because they likely are.
That is such a huge piece. It's almost like you train for crisis and hope you never have to use it. And here we are. So
yeah. And I have to say, like, the nurse that handed me my PPE for my COVID patient, she is a nurse manager from a different unit, she was on a different unit. She was obviously frazzled, but she looked at me and said, do your seal check, have your eyes covered, grab anyone if you need help.
Yeah.
I was like, okay.
Yeah.
And that's the other thing that I think, in retrospect, if I could do one thing different. So for anyone that this hasn't really hit your hospital yet, I would say, and this is my personal opinion, but it is also my professional opinion, I would say having the adequate PPE for seeing any patient, COVID PUI, COVID positive, not even COVID, just assume everyone is having it. Because I think, thankfully, my department has been spared so far. But I know in the rehab department and the respiratory department, there are plenty of people who have gotten sick, and we don't know what or where the breach was, or if there was a breach, and if it had nothing to do with being at the hospital. But it does upset me a little that I didn't advocate for my girls to have the N95s and the face shields right off the bat. And if I could change anything, that is what I would change. At this point in time, we are approved and wearing those for every patient. So we put that on in the morning when we walk into the hospital, and we take it off when we walk out of the hospital.
Good. Yeah, that's so good to hear, Jackie. And I think that's what's so hard is you hear these, this hospital has, this many employees with it. And it's so hard, and there was a huge article in our local paper yesterday. A big local hospital has a ton of employees with it. And then at the bottom was the disclaimer, like, unable to prove if it was, hospital acquired or out in the community, and that's just what's so hard to.
Yeah. And at this point, I mean, I don't even know that it matters.
It doesn't at all.
My director at one
Not
point,
at all.
yeah, my director at one point was using the words like clean and dirty, and, basically saying, are we clean? We don't know. Are we bringing this home to our families? We don't know, but we're taking every precaution we possibly can. I mean, our hospital has erected a tent outside of the hospital for staff to change in.
Yeah.
So, I mean, our staff office is physically located away from the hospital, so we can change in our office space. But I am doing that. I am taking my scrubs off before I come home. I am showering immediately and not saying hello to my family. And, my husband's having to deal with my daughter crying.
Yeah. Oh, yeah.
It's fine. I've gotten really quick at it. He says I'm getting faster.
Oh, good, Jackie. Good. The things you learn to adapt during a crisis. Yeah,
exactly. I was going to say, one of the other things that I think is important, and I know most facilities have a nursing swallow screen. We're a primary stroke center, so that obviously is something our nurses are very well versed in. Some do it better than others, and we had a transition to Epic in the fall, and so the format of it's a little different. So I know that sometimes nurses do it halfway through because ours doesn't say pass-fail anymore, which I really miss that feature. So we are trying to, with our COVID PUIs or our COVID-19 positive patients, we are really asking nursing to do that swallow screen. And I mean, it doesn't have to be a nurse doing it, but when we talk to either the nurse or the provider, that's our first line of defense is, has the swallow screen been done? And if it has, and the patient wasn't initiated on a diet, talk me through what was happening more. Like, let's get into the details of this. And I think that that's been helpful in two ways. One, I think, we're supporting the staff in saying we want to have all the information before we walk in that room because we're limiting the amount of exposure that, we're going to have to ourselves anyway, but also talking them through what things we're looking for so that the next time they have to do one, maybe they'll look for those things too. Maybe they won't because they're overwhelmed and they have a lot going on, and that's totally fine, but we're still going to ask those questions and advise through there. Most of the physicians that I have spoken with, and I tend to go to the physicians first, even though the nurses are the ones that generally do the swallow screen, our facility, they kind of made a blanket statement, like a lot of hospitals are doing right now, about the fact that we are not going to do any instrumental exams, meaning modified barium swallows or fees. And so I think to some people that aren't in the thick of this, that's confusing of why you aren't doing a modified barium swallow. The fees, people seem to understand a little bit more with the component of, being an aerosol generating procedure, having to don additional PPE, because I was on a call last night that they were talking about requiring a PAPR. And I don't even think we have those. Or if we do, they're not reserved for a speech pathologist.
Okay.
And so when our facility made the kind of blanket statement about no instrumentals, we respected that. We took that to heart, and we are escalating issues as we need to.
Okay.
And so we're not doing any fees, but with modified barium swallows, if there's a patient that this is going to significantly change their course of treatment before they are discharged from our facility, we will escalate that, and we have to escalate it to administration, and it needs to be approved before we can move forward. But there is a plan set in place for that. It has required us to be, I don't want to say creative, but I would say it's required me to be more thorough in my clinical exams. And that's not something I want to, I don't know. It sounds bad to like admit that you might not have been as thorough as you should have been previously, but now
it's all a learning. Yeah.
But right now I feel like I'm spending even more time with the patient for two reasons. One, you have the time to, and two, the patients seem very lonely because there is a strict no visitors policy.
Yeah.
But I also feel like it's allowing me to spend more time and just, make sure that the meal is going the way that I think it is in the first 15, 20 minutes of being in there, and just kind of hanging out after and having a conversation. And are they sounding wet? And just looking for all those other signs. Yeah, with the instrumental exams, I think it's important to note that there is a plan, and there are exceptions to the rule, but in general, the reason for that is we don't want to be traveling any of these patients, COVID negative, COVID positive, COVID PUI, through the hallways. We don't want to be exposing additional staff. We don't want to be utilizing rooms that might need to be utilized for other procedures and whatnot. So the hospital as a whole is feeling this in a lot of different ways. And I think our role as speech pathologists right now is being redefined on a daily basis in the light of COVID-19.
Yeah. Thank you for clarifying that, Jackie. I think that's what's so important. Yeah, it's like, well, like you said, why aren't they doing instrumentals? What's going on? I know in some other settings, it may still be, okay to be doing these, but, I think you just explained it beautifully about how it's just really pulling strings. Yeah.
Ours started with, no outpatients, and then it transitioned to, no inpatients. And now I think it transitioned to no inpatient COVID PUI or COVID positive. And then it transitioned to across the board, we can't do this right now. Yeah. So I think most facilities will probably have that kind of hierarchy approach to it. And, hopefully you're learning something from colleagues in New York and in general.
Yeah. You might have to is that going for most other departments too? Like it's
in
not just you guys. Further testing and things like that. It's not just you guys getting picked on.
Yeah, there's a lot that's limited right now. I even noticed, just because we tend to read our dietitian notes, they always do a really good summary, and I feel like they're, our little buddies in the world of the treatment room. And I've been reading some of their notes, and as a department, it seems like, and I don't know this for fact, but as a department, it seems like they've made a statement that they're not going in the room because they can do their interview and whatnot over the phone, and they don't really, I guess they don't have to do their physical exam for their job. I know they like to.
Yeah.
I know they're thorough with it, but I think right now that's a compromise they're making. And I don't know whether that came from them or their leadership, but that was one that I've noticed. I mean, even some of our attendings are talking to the primary team and then determining with the primary team, do you want, the neurologist or the ENT or cardiologist to step foot in the room, depending on what the severity of the situation is. So I think across the board, it's definitely, this is changing the way of medicine. I know our facility, I have one speech pathologist who floats to our ENT practice 2 days a week. And she had called me at one point and was like, they're all moving to telemedicine. How do I do this? And so, I've had phone calls with the director for NYU as an organization for speech pathology about keeping us in the loop, because even though we don't have outpatient on our own, we have her floating. And so anything that they're doing, we can pick up those billing codes and apply. And so they're hopeful that will be out, shortly. But I think I read somewhere about, we waited years for all of this telepractice, telemedicine, and now it's just, in 10 to 14 days, it's just occurring.
Yeah. Yeah. I said that to my husband. We were like standing in the kitchen watching the news, and I was like, it literally took this crisis for all this stuff to just finally happen for us. Like, he was like, Is this a good thing? And I was like, yes. Like,
yeah.
So,
yeah. I mean, I think when this is all said and done, which I think will be months out at this point, but I think there will be silver linings to come from this, and that might be one of them.
Yeah. 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 I love that. Yeah. Thank you for clarifying all that, Jackie, because I think that's what's so important for a lot of people on the outside to realize right now is, kind of what's going on and how do we triage these things? And, it's hard to say, are we just stepping aside? Are we getting picked on as SLPs? Are they just saying, SLPs, you can't do your job anymore? But it sounds like what you're saying, everybody in the hospital is going through the same thing.
Yeah.
Everybody's kind of taking a step back and playing a
collective
role in it.
I'll be honest, our, one of our head and neck surgeons, he is a big advocate for speech pathologists. And so at NYU Winthrop, we used to fall under ENT. And then when we merged with NYU, we now fall under rehab. And so I think sometimes my mentality still goes to that ENT surgery aspect. And our head and neck surgeon was very clear about, you guys need to be protected. And a lot of people don't understand what you do. And I do. And this is what you need. And I mean, he almost basically instilled fear into me. To get me to understand the severity of this. And he, I'm glad he did. I'm glad that conversation happened. And he initially had it with the speech pathologist that floats to his office, and she called me, and then I called him, and it was this whole phone chain of events, but it was very helpful because that is where I was able to escalate then to my director, who is not a speech pathologist, but I was armed with my information. I was armed with my research studies, and I was armed with a physician backing what I was saying. Yeah. And I think that that's huge. And I think every facility is going to have to do what works for them. Every speech pathologist is going to have to do what works for them. But knowing what's going on in our facility, what our resources are, and being able to redefine our role within that is important. And I think we're also being respected for it.
Yes. Awesome. I love the way you said that, Jackie. I think, and that puts such a good perspective on it too, because I think, as being an SLP that works in SNFs, we have no relationship with ENTs at all. So when this ENT statement came down the pike, a lot of us were like, well, what do they have to do with us? We're completely rehab. We have nothing to do with them. Okay. But like you said, you guys, identify closer with the ENT department than the rehab at one point. So that makes total sense for your setting. And I think that's, like you said, we've all just got to consider our own settings and our own, what we're dealing with.
Yeah. So one of my per diems, when this all kind of started to hit New York, had called me saying that her facility wasn't going to allow her to work somewhere else because if she ended up sick, she wouldn't be paid out. That has since changed. But initially, we utilized per diems pretty heavily for our weekend schedule. And so I had to pull her from the weekend schedule. And that's actually where the transitioning to the 410s kind of came from, and throwing myself into the normal rotation of every weekend and whatnot. And I have 2 staff members that were pretty willing to do a majority of weekends because there's nothing else going on right now in New York, and you don't really have a social life. Yeah. So they were like, sure, 3 days off in a row, I'll work every Saturday for you. And so with that transition, we basically redid the entire schedule for the month of April and working through that. And normally we have our schedule done 3 months out, and I'm barely doing it 3 weeks out at this point because we're just concerned about the changes that might occur. We're concerned if one of us gets sick, what does that mean for the department? I know some facilities, if they're, if a staff member got sick and you were technically exposed, you were out for 2 weeks as well. We are no longer doing that because I think we would be extremely limited with hospital staff. Yeah. So there's a series of questions that you have to go through to make sure that you can come to work, that you're asymptomatic. My entire department, we are checking our temperatures twice a day anyway, just because we all feel better doing it. Yeah. So the per diem aspect, I think, is interesting because I'm sure a lot of facilities are just kind of grasping at straws of what do they want to do? How do they want to manage this? And It's obviously impacting other facilities, including their own, because then other settings change the rules, and it's just constantly changing. I have a list of websites on a daily basis that one of us checks just to make sure we're, all on the same page about what is going on. Some of those resources I got from you.
Yeah. Awesome. Well, and I think what you said is, everything's changing daily. And I think, we can have these best plans put into place and then it can all just go to hell within a day or two. But, I know some facilities are saying like no per diems whatsoever, because like you said, they don't want them traveling from facility to facility. But then when it gets insanely busy, they're calling in everybody in the world, people that don't even have a license, so I think we can do the best we can with what we have at day one, and it's definitely going to change by tomorrow. So
yeah. And my hope is that by taking my per diems off of my, what I'm calling normal schedule now, that if I do end up with a staff member that's sick, that hopefully I will have a per diem to call in. Yeah. Because otherwise the rest of us are having to pick up that slack, and that is to some degree not necessarily feasible all the time. But we'll cross that bridge when we get to it.
Yeah. I think that's all anybody can do. So how do you think you guys are doing? Like, how do you think you're faring mental health wise?
As a department, I think we're doing okay. I've been making a point to check in with pretty much everyone on a daily basis, at least when they're at work. I'm trying not to bother my staff when they're home, but it is a little hard right now because, needing to check remote access or whatever, just seeing if certain things work right now. I feel like they don't get a true day off where I'm not asking them a question, something work related, which I don't love because I think that break is important, but I also recognize that there's a ton going on right now.
Yep.
You know, I tend to sign most of my emails with a meme or a funny video clip or something like that. I mean, that just is my lighthearted way to do things. Hopefully that's well received.
Yeah.
I think that we're all trying to have each other's backs. And I think that before this started, we were a very close-knit team. And I think that that's just further developed, that aspect of us. I do think that in regards to our nursing and our physicians, I think that they are spread thin, and I think that they are stressed. And I don't say that in a mean way. None of them, no one's being mean to each other. It's just, you can tell by their face.
Oh, yeah,
They're stressed.
Yeah.
You can tell by, how they're rushing. I mean, it's impressive to me that we're still functioning as well as we are as a hospital. I think that the facility is doing a really good job of trying to listen to feedback from employees. For me personally, every time I step foot in the hospital, a different unit has been converted, and that is eye-opening in a positive and a negative way. It's alarming that much change can happen in overnight, basically. Yeah. But it's also really impressive to see engineering and everyone else, IT, everyone else getting these rooms. I mean, our entire conference room is now a unit. I mean, it's literally a unit. Our OR, because elective surgeries aren't happening, has patient beds in it, and it's basically a unit. So I think that that's, there's so much to that. And I think as an organization, I think we're faring fairly well given the circumstances we are in. I think that, one of the things I've talked to my colleagues about, not necessarily at my facility, is that every hospital seems to be handling the communication to their staff differently. And I'm very appreciative of the fact that our hospital seems to be sharing that information with us of what cases, how many cases do we have, and where are we at? Where are the testing centers? What's happening with the turnaround for testing time? And just, we basically, at this point, I believe those emails are weekly. As a lead therapist, I get daily emails, which I'm sharing with my staff in regards to certain numbers at our facility, specifically. And then, just in conversations with your respiratory therapist or your physician or whatnot, you're hearing other information, but you don't always know the integrity of that. Whereas the emails that are coming out from either, the CMO or the CHO, you obviously have more faith in because they're being printed and sent to you.
Yeah, I think that's so important. I don't know. And I don't know why facilities are keeping this information from their employees. I can't.
Well, I don't know if it's intentional. I mean, it might just be they're not really thinking through it, or they haven't gotten the feedback. Yeah, I mean, I can't speak to that. I'm just appreciative that ours isn't, because I think it's making staff feel more comfortable and a little bit more empowered. Yeah. And I think that that's an important thing right now. I think that, as I've been at my hospital since the summer of 2015. I've been in a leadership role since the spring of 2018. So actually the speech pathology program started with my prior boss at NYU Winthrop. Prior to us, there was a contracted service that came in, and they wanted to move to a model of 7-day coverage and whatnot. And so I've seen a lot of transitions within my department, within this facility. And I think that, there's been a ton of growth, and this is just going to be another example of how we grow and how we manage and how we overcome.
Yeah. I think, kind of going forward, I'm so curious to hear how things shake out once the slew of post-extubation patients come. And, I've heard talk of some other facilities almost having, in light of preserving PPE and things like that, almost having the nurses basically do the clinical swallow exam for you, you standing outside of the room. And obviously that's something that would never fly in a normal condition, or how that affects billing or anything. But do you suspect that might be something that you guys have to go to too, or?
I don't know. I think that more depends on the availability of the N95s and the gowns, because our School of Medicine is making eye shields currently.
Oh,
so
awesome.
From the email communications, I'm understanding that is an area that they're not anticipating as much restriction with the eye shields. But in regards to the N95s and gowns, I don't know exactly where we fare. So I think that it will really depend on the amount of supplies we have. So in regards to the post-extubated COVID-19 patients, what have you been hearing so far?
I actually I'm recording another podcast tomorrow with some people that have seen kind of some of the literature coming out of China and things like that. So I can't answer that specifically right now. I just keep hearing from everyone that's saying the swallow is just weird. And and it seems like that's what everyone's saying. And I don't know what constitutes weird. I don't know.
And I wonder if it's because we don't have the ability to do an instrumental, if, things just seem different. I don't know. Yeah. I'm curious for when we start seeing those consults and whether we can actually start seeing those consults, or whether we're standing at the door. I know our facility is trying to look into getting the iPads so that we can kind of do a telemedicine aspect in the acute care setting, but I don't know where we're at with that.
Oh, fantastic. Yeah. Yeah. So, someone else had mentioned to me that they're looking into almost doing some sort of like telemedicine fees, like having like a physician, if a physician's already gowned up in PPE, considering doing some sort of, having them pass the scope while you're viewing it from the outside. They're trying to come up with some sort of way, kind of once these post-extubation patients, the slew of them comes out, how they can preserve PPE if it's a physician that is, has experience with passing a scope and they were planning on doing something of that, if it was a respiratory therapist doing a bronch or something like that too, just trying to think creatively of how we can somehow get the imaging. Yeah.
Yeah. That would be interesting.
Yeah.
I don't know.
Yeah. I don't know either. Someone was like, have you heard of this? I'm like, no, there's so much stuff no one's ever heard of that it's like, oh, that would be cool if we could do that someday,
Yeah. Everyone's having to get creative.
Yeah. I mean, how many respiratory therapists have said, oh, could you just like keep going so I can see my part? It'll be interesting to see how many physicians or ENTs are now passing the scope for everybody so everybody can get a view. But
well, and I know our ENTs are trying to limit the amount of endoscopy that they're doing significantly. So I would be surprised to see that happening on the inpatient side. I feel like that's something that would happen more when they've tested negative and they're in the office.
Yeah.
But that's my own speculation. I don't have anything to base that on other than conversations.
Well, thank you, Jackie. I think you covered everything.
All right. Thanks, Theresa.
Thanks so much for sharing everything. I think, just you being kind of in the thick of it, or about to be in the thick of it, I think is just really helpful too. That seems to be all the questions. Everybody's like, how do we even attempt scheduling? How do we even attempt staffing? And so I think you gave some really good considerations for that.
Yeah. And I think it's really hard to predict something you're not at yet, because I know, when people were talking to me about how bad this was going to get, it was really hard to see my schedule with, X amount of staff on it dwindle down and have to reshape that and take the per diems off. And it's just like, well, wait, why am I doing this? And, conceptually, you obviously understand it, but it's really hard to make all of those changes before it hits your hospital.
Yeah.
And thankfully we still, we did. And I had a lot of leadership supporting the decisions we were making and the changes we were making, because they knew what was coming. But I still feel like I was struggling with that, just on a human level of like this, it's really hard to do something when you're not seeing it.
Yeah. Yeah.
Well, now we're seeing it.
Yeah. Well, it's not like people have events going on the weekends anyways that they can't cover.
We are all
unfortunately.
Yes. I've heard of a lot of Zoom happy hours, but
yes,
you could do those on Wednesday.
Yeah, my husband scheduled one last night, like prime kids bedtime. I was like, no, we got to get the kids to bed. You can deal with that later. So yeah. All right. Well, thank you so much, Jackie. I really appreciate it.
Thanks for having me on.
Yeah.
If you enjoyed this video, please like it, offer a comment below, and subscribe for future episodes. Thanks for listening.